Welcome to A New Prescription, where we explore modern healthcare, cutting-edge medical research and technology, and the complexities of healthcare politics. Join us as we provide insights and solutions to help you navigate the American healthcare system. Welcome back to A New Prescription, a podcast where we help you navigate the American healthcare system. I'm your co-host, Andrew Zwelling, and with me, of course, is Dr. Leonard A. Zwelling. Dad, say hello to our viewers.
Hi, everybody. Welcome back to A New Prescription. We have a terrific show planned for today, a really important topic. I can't wait.
So if you haven't been living under a rock, you've undoubtedly seen the GLP-1 weight loss drug commercials everywhere. From popular jingles like Ozempic to social media blitzes from these companies promising you a healthy future after taking these drugs, or even direct-to-consumer services like Roman, these GLP-1 drugs are everywhere and available to millions of patients across the United States. But should we believe the hype? Are they effective long-term? Who should be taking them? And are there any long-term adverse effects for taking these drugs? We're going to discuss that all and more in this week's A New Prescription episode entitled Ozempic, the Good, the Bad, and the Ugly. And with us to discuss all this is our special guest, Dr. Efstratios Kountrampakis. Dr. Kountrampakis is an assistant professor of medicine in the Department of Cardiology at MD Anderson Cancer Center in Houston. I'd like to mention that in 2019, he was inducted into the Alpha Omega Alpha Honor Medical Society, and he joined MD Anderson in July of 2021. Dr. Kountrampakis, thank you so much for joining us. We're so excited to have you.
Thanks for having me.
So, Doctor, where I want to start is, why should we look at obesity as a chronic disease?
Yes, for a long time, people thought of obesity as a matter of appearance or personal choice. But now we know that it's more than that. Obesity is a chronic, complex disease that affects nearly every organ in the body. It's not just a matter of extra weight. It's a matter of how excess fat causes inflammation, changes metabolism, and leads to development of diseases like diabetes, heart disease, or even some types of cancer. Now, when we think of other types of chronic diseases like blood pressure or diabetes, we don't just tell people try harder to fix it. We implement medical interventions, and obesity should be no different than that. Obesity, we know that losing 5 to 10% of body weight, if you're obese, that leads to significant health benefits and improves longevity. So we need to change our mindset and think of obesity as a chronic disease, and that will help us manage obesity better, both in the personal but also the population level.
So when I was a young doctor, I didn't have these kinds of drugs. All we really had was diet. And then further on, we had surgery. Talk about that part of medicine when we had that and how things have changed so dramatically of late.
Yes, that is right, and still to this date, lifestyle modifications like exercise and diet remain the foundation of managing obesity. But for a lot of people, those two are not enough. Okay, and that's because obesity is driven by strong biological and genetic factors, and over time, as we age, our body fights to maintain a higher weight. So in addition to lifestyle changes, now we have medical interventions, including medications and bariatric surgery. Bariatric procedures such as gastric bypass and gastric sleeve are being used now for several years, and they can lead to significant weight loss. A lot of people have lost up to 25% of their body weight. And in some cases, they can also help treat diabetes. So bariatric surgery is important, but it's surgery. It comes with a lot of complications potentially. The risk of complications is high, and it's not for everybody. And that's where the new medications, GLP-1 agonists, come in play. And it's very exciting for all of us to think that now we have medications that can achieve such a large degree of weight loss in ways that we did not have available before, adding to the tools that we have available to treat obesity as a chronic disease.
So let's talk a little bit about GLP-1s. First off, most importantly, what does GLP stand for and how are they discovered?
Yes, that's a great question that confuses a lot of people. GLP-1 drugs mimic a natural hormone in our body called glucagon-like peptide 1. Okay, the body produces that hormone to regulate glucose and control appetite. Now, GLP-1 drugs mimic that hormone, and they were originally developed to treat diabetes. But then it was observed that people were less hungry and they were losing weight. So there's actually a pretty interesting story behind the discovery of these drugs, and that is that they were inspired by the saliva of the Gila monster, which is a type of lizard. Scientists found a compound inside in its saliva that worked just like GLP-1 peptide, but it lasted much longer. So that led to the development of GLP-1 drugs. And we use them today. They work in different ways, but three main of them are the following. They work in the stomach. They slow down how quickly the stomach empties. So that leads to people get fuller after they eat for longer and sooner. Uh, they work in the brain. They suppress appetite and the hunger areas in the brain, so people don't feel the cravings. And they also work in the pancreas, the regulating sugar. So we don't have the spikes, drops in sugar in the bloodstream, which leads to cravings. So by working in all these different areas in the body, they are very effective, and their benefits extend beyond the weight loss.
We hear a lot on TV about the benefits of these drugs. Are there common side effects? They're always in the fine print or they come after the end of the commercial. What are the full array of benefits and what are some of the common short-term side effects that we see with these drugs?
Yeah, no, that's definitely a great point. And GLP-1 drugs gained a lot of interest now because they work against diabetes, weight loss, but their benefits extend beyond those two things. So of course, the most obvious benefit is weight loss. People taking these drugs can lose up to 20 or 25% of their body weight, and that is very significant. But beyond that, we now know that these drugs prevent heart attacks and strokes or heart failure events in people with obesity related heart disease. They also prevent or they help treat diabetes. There is other studies that show that they prevent neurodegenerative diseases such as Alzheimer's, dementia. Other studies have shown that they might reduce inflammation in diseases such as arthritis or fatty liver disease. So it's a whole gamut of benefits that we are constantly learn, and the research is going on and on. There's a lot more to be learned about the benefits of these drugs. Now, with that being said, like any medication, they come with a cost. They do have side effects. The side effects are common. Up to 70% of people in the studies have reported some side effects. Now, most of them are mild and they improve over time. The most common side effects are nausea, vomiting, constipation, diarrhea, especially at the beginning. That's why when we prescribe these medications, we start with a very low dose and we escalate very slowly. So the body gets adjusted to the medication and people don't have those GI effects. Now, beyond those mild side effects, there is other concerns that have been raised, especially from early studies. Those were a condition called pancreatitis, which is a serious inflammation in the stomach, and also thyroid cancer. Now, those were concerns that were raised from early studies, primarily in animal models. They have not shown to be true in subsequent large-scale studies. So even though there is still a black box warning by FDA, And we don't use these drugs in people who have recurrent episodes of pancreatitis or prior history, either personal or family history of thyroid cancer. We don't think that it's a true concern. Now, of course, everybody should talk to their physician and assess their own personalized risk or side effects when they try to decide whether these drugs are appropriate for them.
What is the buildup of these drugs in terms of you start with a low dose and then work your way up? What does that look like? I think it'd be great for our viewers to understand that when they're going in and asking about these GLP-1 drugs.
Yeah, exactly. No, that comes up a lot. So as I said, we escalate the dose progressively. We start with a very small dose. Now, the drugs that we use currently, they are injectables. We patients inject them under the skin. Now that sounds scary, but the injection is painless. The needle is very small. We start with a very small dose. It's done once weekly. Okay, most patients are able to do it to themselves. Every roughly 4 weeks, we try to escalate the dose. Now, if someone experiences a lot of gastrointestinal side effects, nausea, vomiting, then we might decide to delay the escalation. Usually, there is 4 or 5 doses that we go up progressively until we achieve certain doses that have shown to achieve the most result. And again, every patient is different. So for some people, a lower dose is more appropriate. For others, they need the highest dose to see the result.
We certainly hear about more than one of these drugs. And sometimes the commercial is for obesity, and sometimes the commercial is for diabetes. Can you sort that out for us? How many different drugs are there, and why is it so confusing?
Oh, it's definitely confusing even for medical providers because there is different names for similar medications. But to make it simple, there is two popular FDA approved medications for weight loss. Okay, there's going to be much more as the years come, but for right now, there is two of them. The generic name, the name is semaglutide and tirzepatide. Okay, those two. Semaglutide is mimics one hormone in the body, GLP-1, and it's marketed under the brand name Ozempic, which everybody knows. But it's sold under Ozempic when it's prescribed to control diabetes. The same substance is marketed under the brand name Wegovy when it is used to control weight in the absence of diabetes. Okay, the other medication that was developed more recently is called tirzepatide. Now that mimics two hormones, GLP-1 and another hormone called GIP, and that's why it's probably more effective too. Now, again, tirzepatide has also two brand names. One is Manjaro when it's used for diabetes control, and the other is Zipbound when it's used for weight loss. So, two medications, they both work. Tirzepatide is probably more effective. And the medical providers, when we choose one versus the other, we decide based on the patient's medical history, insurance coverage, and how they respond to one treatment versus the other.
You've named, you've given them brand names. Or is there a generic form of these drugs that are available? Because you always hear they're associated with other commercial products, and yet it seems to be the same substance. How is that possible? These off patent already that they can be made generically?
Yes, no, they're not off patent yet, and that's why the prices are very, very high. Currently, uh, the coverage and the cost of medication is a major issue. They cost more than $1,000 a month. Most insurances will not cover, and especially when it's for weight loss, they will cover when it's for diabetes. But even when they cover, the copays are high. So what is done? There is a lot of substances out there in pharmacies that they are compounding pharmacies, and they use a similar substance. They are FDA approved, but they're not the brand name. So people, when they get these medications from compounding pharmacies, they will get the vial. Then they will have to aspirate and get the exact amount and inject it to themselves, as opposed to the pre-filled syringe that comes with, when you get the brand name from their company.
Okay. So are there any drawbacks between getting it from like a compound pharmacy, and I assume like Roman is in that category, compared to getting it from your doctor and getting the brand name Ozempic or a Monjaro?
Yeah, I would say there is definitely pharmacies that give a good quality product, but there is also a lot of people out there that try to make money of all of this. These drugs are so popular, everybody wants to be on them, and the cost is prohibitive for a lot of them. So what I would say is be careful, and if your physician knows of a pharmacy and it's real, and the medication is proven to be effective and of good quality, then you go for it. But I would be very, very careful where you get these
Right.
drugs from, and the things that you inject yourself could have serious side effects. So
So
um,
so it's really the quality that comes with the
and
injection of the medication.
the effectiveness, the other substances that might be mixed with the medication. So who knows if it's not regulated, it can create a lot of issues.
Before we move on to the next piece, I did have a question about semaglutides and tirzepatides, if I pronounce that rightly,
Yes.
right? Are there trade-offs to picking each class of family between the two? I know you said you take the history to decide which medication to put the patient on. Are there trade-offs between those two that patients need to think about when they're making these decisions?
Yes, good point. The there is the companies are trying to come up with indications for one versus the other. So, for example, there was a big study called the SELECT study, which used semaglutide, and it showed that it prevented heart attacks and strokes. So the company used that to say, okay, maybe you don't lose as much weight, but you might have better cardiac benefits. So they market. But then now, more recently, there was another study, Summit study, that showed probably, tirzepatide has equal cardiac effects. I think it's the class that has all the benefits. The tirzepatide has been directly compared with the semaglutide, and it's more potent, more powerful. But maybe it's not for everybody, and we're still learning. So I would say the way I use these drugs, if someone is diabetic, they've been on Ozempic, semaglutide. Usually, I will not, and they are they're responding well. I will not change it. If someone with a lot of extra weight wants to start now to try one of these drugs, then I would go with the tirzepatide because it's more potent. Okay, side effects wise, you would think that because it's more potent, maybe it will have more side effects too. The studies have not really shown that, but it's logical. Maybe because it mimics two hormones instead of one. So maybe the GI side effects are a little more prompt.
One of the things you mentioned briefly in the beginning is obesity is a risk factor for cancer. Now, these drugs can reduce obesity. Does anybody know if they have any effect on the sensitivity to getting cancer?
That's an excellent question. It's very close to my heart. Working at the cancer center, this is a topic of active research currently. But I would start by saying that there is at least 13 types of cancer that have been associated with obesity, including breast cancer and uterine cancer in women, pancreatic cancer, colon, liver, and stomach cancer, just to name a few. And thinking about it scientifically, we know that obesity and excess fat causes inflammation. It causes insulin resistance, and that can lead to tumor growth. This has been shown. So even though there is no direct proof that these drugs can prevent cancer, the logic is there. Okay, and we hope that down the road we'll be able to prove that. Now, there is some animal models, that have shown that these drugs, beyond causing weight loss and beyond preventing cancer through losing weight, they might even have direct anti-cancer effects. Now, again, this is very limited evidence, early studies. We don't know anything for sure, but there are some animal models, mouse models that have shown that mice who received GLP-1 drugs had a slower growth of colon cancer and pancreatic cancer. So there is a lot of excitement in the field. Um, Currently, there is another issue in patients who have already cancer, then they're treated actively with chemotherapy. It might be difficult to give these drugs because of the GI side effects. People with cancer who are treated with chemotherapy very frequently have nausea, vomiting, and we don't want them to lose weight at that phase necessarily. So, but at the same time, there is types of cancer that now have become chronic diseases. People survive decades after their cancer, and in those patients, using these drugs could potentially prevent recurrences of cancer. So a lot of excitement, not much data yet, but as I said, there is a promise. And if I make a prediction, I would say that I expect these drugs to be an important part of therapy in the future, both for preventing cancer in obese individuals, but also uh, uh, being part of the treatment of patients who have already been diagnosed with cancer.
Excellent.
So, can you just give us a patient profile or even a success story without naming names, of course, of people that have come in or patients that have come in, they've had heart disease, they've gone on GLP-1s or they have cancer and they've benefited from these drugs? I think it'd be great to hear some of the success stories.
Oh yeah, absolutely. And this is so rewarding and makes me so happy because there's not that many medications that you give to people and make them feel so much better in a relatively short period of time. Okay, we talk about giving preventative therapies and lower the cholesterol and but nothing makes the patients as happy and excited and make them feel as good as these drugs now do. And we have several examples, and even colleagues of mine have been using it, and they've lost a lot of weight. But the one example that I will mention is of a patient of mine who had a history of lymphoma. When he was younger, he received chemotherapy that is known to be toxic to the heart, and unfortunately, he did develop heart failure. His heart got weaker over the years. As a result, he was on a bunch of medications, 6 different medications to lower the workload of the heart, lower the blood pressure, restore his heart function. But the damage to his heart, because of the scarring that had been developed from the chemotherapy, was permanent. So the heart function was not getting better. He wasn't taking chronically these drugs. And this is an individual now. He was in his 40s. Okay, so he had cancer when very young, and this whole thing was very mentally distressing to him, and being needing to take a bunch of medications on a daily basis and being afraid that your heart disease will progress is a major thing for him. And so we decided, of course, he had a lot of extra weight, and we decided to try these medications because of some early signals that they might help with heart failure events in patients who have heart failure or reduced heart function. So as a result, to make the long story short, he lost a lot of weight. He responded very well. He came off of 4 out of 6 of his medications, and he feels so much better. And he's so thankful. He's sending me messages every few months saying how grateful he is. And we didn't have those options in the past, and this is very exciting. In the past, we would say, okay, you follow diet, strict diet, and exercise, and we know that yes, can follow a strict diet, but only for a limited period of time. There is studies that have shown even the strictest diets, they might work for a year or so, but then people become less religious about it, and over time they regain back the weight they lost. And it's a matter of a lifestyle. It's not just try to follow a diet, because every day at work or we go places and we don't have healthy, good food options. It's not just a matter of willpower. It's a matter of accessibility to healthy diets and exercise. We go everywhere with our car. So diet and exercise not very successful in our society, at least. These drugs now very evolutionary. They have helped a lot of people, and I predict that they will continue helping more and more, and we'll have more success stories.
One of the things we hear is that when people stop taking these drugs, they automatically gain all the weight back. Is that because they regain their old eating habits, or is there something about not being on the drug itself?
Excellent question. And this was studied in a large study. And within 1 year after people discontinued this drug, 2 out of 3 of the patients regained back their weight. Okay. And if we followed them longer, I would think that probably all of them would regain. So yes, that is true. If when you stop the medications, weight comes back, and that's a result of different things. The old eating habits come back, yes, because the medication works in the brain. It kind of makes people to be able to suppress their appetite naturally. They don't feel cravings, and it's so much easier for people to eat less when they take the medication. When you stop taking it, your body fights to gain more weight. There is as we said, strong biological genetic factors that are involved. Um, so yes, unfortunately, this is a medication that will have to be continued long term. But in patients who already have developed obesity-related complications such as diabetes, high blood pressure, high cholesterol, they are already committed taking medications for lifetime. And instead of uh, giving them medications to treat complications of obesity, it's preferable to treat the source of the problem, which is the extra weight, and then de-escalate the medical therapy, potentially give one medication or instead of several that they take to treat the complications from obesity, along with the other benefits that they might have.
And yeah, I want to go into that piece about if you stop taking it, you can regain the weight. I have a lot of friends who are 20s, 30s, in pretty good shape, or even like the Hollywood stars, they're taking it to lose weight for their action roles, etc. Are there any downsides for a healthy 30 to 40-year-old patient taking these drugs if they don't have any of the comorbidities or the cancer type scenarios you discussed on today's podcast?
Yes, that's an excellent question. It comes up a lot. A lot of friends of mine, I'll call it, they approach me and say, "Oh, hey, give me that drug. I just want to drop a few pounds." Well, I would say this: these drugs are really beneficial, and they're really meant for people who have obesity or weight-related health problems. Okay, for these patients, they truly help, and they save them for a lot of health issues. Now, when it comes to younger people, overall healthy, who want to lose a little weight, I would say we should consider 4 or 5 things. Okay, number one, these medications, like every medication, do have side effects. Okay, so um, although most of them are mild and they resolve over time, there is others that are more serious ones. And the second thing is significant muscle loss. So because of the rapid weight loss, together with that goes muscle loss. So that's why we always advise our patients to stay active and work out, because you will lose some muscle mass, which I don't think it will be desirable for young people. Number three, weight regain, as you said. How long are you gonna be taking it? If you're young, are you gonna take these meds for the rest of your life? Okay, because the chances are when you stop the drugs, you will gain back the weight. Okay. Yes, we will give it sometimes, and people might we might try to be optimistic and say, okay, well, I'm gonna learn what my lifestyle should be, what I should be eating, and then try to stick to it. But not a lot of people can stick to that lifestyle. Okay. And then the final thing that we need to consider is accessibility, cost, and insurance issues. Right now, the people who will benefit the most are people with diabetes or already obesity related health issues. And that's why the insurance is covered only for those people. if all of us want to go on it, the companies wouldn't be able to produce the amount of drug, and then and then currently the cost is significant, more than $1,000 a month. So I don't know how long someone is willing to pay that amount out of pocket just to lose a few pounds. So when people ask me, I still recommend diet and exercise is your best bet, even though we talked about the limitations of those interventions.
This has been absolutely fascinating. I think that our young people really need to hear that, especially that last piece about how there are trade-offs to taking these drugs. It isn't a surefire bullet to success on all facets, and it really should be reserved for those people who are obese or have comorbidities. Dr. Kuntrampakis, is there any last words that you have that you want to give to the people? It's been great having you. I've learned so much. Anything else you want to add?
Um, I will say that, well, first of all, thanks for having me. This was a pleasure, and I love talking about this topic. I would say that stay tuned, because there is a lot of medications in this class that are actively being tested, and they will hit the market. So hopefully insurances will start covering more, Medicare will start covering, and maybe not too long from now, these medications will be available to a larger portion of patients. So they have great potential. Also, some side effects that need to be considered, but overall, very exciting. Us as cardiologists, I say that we're a subspecialty that sees the largest portion of patients that might benefit from these drugs. So my colleagues and I should start using these drugs more and more as a good preventive therapy, because they do prevent heart disease. And they prevent heart disease not only indirectly by losing weight, but also there are signs through recent studies that they might also have direct protective properties in the heart. And they can prevent heart attacks, strokes, heart failures. So a great tool to add to our toolbox as physicians. We're all very excited to see what the future holds. And maybe in a year or two from now, we'll have a follow-up conversation, see where we stand. But again, thanks for the great conversation.
Yeah, we'd
Thank
love to
you.
have you back, because I think there's going to be a lot of data coming in that you're going to be evaluating that's going to help make the picture more clear as to what these drugs can and can't do. So we would definitely love to have you back. Dr. Kuntrampakis, thank you so much for joining us. We really appreciate it.
Of course, my pleasure.
And that's all for today's show of A New Prescription. If you want to continue the conversation, remember, join us on our social pages. Our handle is @A-New-Prescription. You can also see this video on YouTube @A-New-Prescription YouTube. Remember, your health is the most important thing to you. We can't wait to see you next time.